Thank you. I really appreciate the opportunity to speak to you on a topic that's near and dear to my heart. A few mandatory disclosures. I am doing some research on these topics, but also involved in various societies that are impacting the ongoing translational work, development, and guidelines, practice guidelines for liver fat quantification. So we know chronic liver disease is very common. We perform ultrasound of the liver many times a day in our practice, but we should all be knowledgeable enough now to know that fatty liver disease is the #1 cause of new cases of chronic liver disease in the United States. So for this presentation, I will be focusing on fatty liver disease and reviewing the epidemiology, conveying the need to quantify liver fat and the utility of ultrasound in this space, describe emerging techniques for liver fat quantification, and highlight some future opportunities. Now, fatty liver disease is very, very complicated. There's this two-hit model they talk about in the literature. I don't have time to get into the details, albeit to say that it's often multifactorial, but it is a situation that sets up chronic inflammation, the same kind of inflammation you would get in alcohol overuse or viral hepatitis, and will lead to chronic liver disease. And in fact, the nomenclature is actually changing. So we now have steatotic liver disease as renamed by the nomenclature consensus group led by the AASLD. All of us know NAFLD and NASH, but keep in mind that the terms have now changed. So those terms are passé, and they are now MASLD, metabolic dysfunction associated steatotic liver disease, and MASH, with the steatohepatitis, but those are not the only causes of steatotic liver disease. Keep in mind that alcoholism and drug-related liver injury are also causes of steatotic liver disease. If we assume a general population of over 330 million people, a third of those are going to have MASLD. Okay, so that's 100 million people just in this country. A large percentage of those will have superimposed steatohepatitis. That's 20 million people. And this new category, at risk, MASH, are those patients that are at highest risk for progressing to cirrhosis. Is about 3% of the population. That's 5 to 10 million people. And this epidemiology is seen worldwide with an estimate of 1.6 billion people affected around the world. So why is it important to quantify liver fat? Well, in a screening situation, you're trying to identify patients who have steatosis so you can implement some kind of treatment, whether it's lifestyle modifications, medications, et cetera, and follow them over time. And then, because there are some studies to show that greater fat content is associated with a higher risk of steatohepatitis. Once you identify those patients and they're on some kind of therapy.
My name is Jena Depetris. I'm from UCLA, and I have the pleasure of speaking with you about vascular ultrasound of transplanted organs. I'd particularly like to thank a few of the speakers who came before me who reviewed some normal vascular parameters in native kidneys and livers, so I can focus really on transplanted organs. And just as a point of outline, I'm going to be focusing today on kidney and liver transplant, the two most common transplanted organs worldwide. I'll be focusing first on normal transplant anatomy, moving on to normal vascular parameters, and then we'll get through some cases highlighting several important vascular complications. And just for full disclosure, these are the cases I'm going to be reviewing. We'll start with the kidneys. We'll review renal artery and vein thrombosis, renal artery stenosis, and AVF, and then move on to the liver to talk about hepatic artery thrombosis, stenosis, and portal vein stenosis. I have no relevant disclosures. So let's first talk about renal transplant, the most commonly transplanted organ worldwide. It's really important for us as radiologists. The surgical techniques have improved, immunosuppressive regimens have improved, and allograft survival is continuing to improve, and so these are becoming more common, and it's really critical that we understand what a normal renal transplant looks like on ultrasound. It's usually located extraperitoneally in the pelvis in either the right or left lower quadrant, and it involves 3 new anastomoses, 1 arterial, 1 venous, and 1 ureteral. So the renal artery is usually anastomosed to the external iliac artery, the vein is anastomosed to the adjacent external iliac vein, and the ureteral anastomosis can be done using several different surgical techniques, which I won't really discuss today, but it sort of depends on recipient and donor organ anatomy. In terms of vascular ultrasound, so Doppler ultrasound we use very routinely in the evaluation of transplanted organs. It provides an excellent baseline postoperatively, and also we use it routinely for surveillance and development of vascular complications, among others. First, it's important to look at global allograft perfusion. Using color Doppler, we should see very extensive, good perfusion throughout the entire allograft. We can then go on to evaluate the interlobar arteries. We want to look at the arterial waveforms and the resistive indices. And so a normal arterial waveform for an interlobar artery should show that normal rapid systolic upstroke with persistent diastolic flow. And a normal RI range for a transplanted organ is between 0.5 and 0.7. We then look at the renal vein, look at its flow and waveform, and this should be continuous flow with respiratory variability, not very different from what you might see in other organs. And then we look at the renal artery, usually interrogating it in at least 3 locations, the hilum, the mid-RA, and the anastomosis, and this similarly should have a rapid systolic upstroke and persistent diastolic flow. So, focusing today on vascular complications.
So we're going to finish up today with the ultrasound-assisted GYN interventions. Why, when, and how. I have nothing to disclose, but I did want to bring up that this talk and a lot of my work is in collaboration with my colleagues, my talented colleagues, Dr. Falstein, Morgan, Shum Sugi, and also my clinical colleagues. And if you have time, if you wanted to take an image of this and go to the RSNA exhibit on ultrasound guided interventions. It has more details and it's beautifully narrated by Dr. Morgan. Actually, you can download the PowerPoint online. So it's very helpful if you want to get started in your practice with that. So you can have ultrasound-assisted GYN interventions in different ways. It could be endovaginal, endorectal, or transperineal, but we're going to mostly focus on endovaginal procedures. So endovaginal ultrasound guidance can be oftentimes the shortest, the most direct approach to access pelvic pathology. It could be for FNA, for core, for aspiration, or drainage, and it really can significantly impact the patient's management. It's very safe, it's well tolerated with pain control, and it's just surprisingly easy. However, it requires some willingness and some experience. So, and when do we, most of the time we do it? Because it's when it's very, there's no other access really to those lesions. So for instance, in this case, on the CT down below, there's this tiny little nodule. It was recurrence suspected in the pelvis, and it was, it was near the vaginal cuff. And it was surrounded by adjacent bowel. They did do a CT-guided biopsy twice, and the little tiny nodule simply just moved away. They were not able to get a tissue specimen, but it was really easy to access this and directly go into it with the ultrasound guidance, avoid any of the adjacent crucial organs, and get the tissue diagnosis. So I just wanted to, again, earlier today, there's been some beautiful illustrations of the transperineal anatomy and also how to correlate cross-sectional to the ultrasound anatomy. And it really comes handy when you're sometimes trying to do those procedures. So here's an example of a 48-year-old with metastatic breast cancer and had this new enlarging periurethral mass, hypervascular on the CT. So you can see the arrows on the mass, and just wanted to a little bit review the anatomy, what we've seen before, and then relate from the CT. So this is the urethra, the smiley face, vagina right behind it, and you see that hypervascular mass anteriorly to it. And you can see that it's fairly impossible to reach this with a CT because it's like the pubic symphysis is on the way. How are we going to get any access? Like, what could this be? And we're like, well, let's just take a look. Maybe.